I'm Dr. Tom Haberman, Mayo Clinic, Rochester. I'm a professor of medicine at the Mayo Clinic College of Medicine and Sciences. Lymphoma is a kind of cancer that affects the lymphatic system. It affects the lymphocytes. They can be B lymphocytes or T lymphocytes. This can involve lymph nodes. The lymph nodes are connected by lymph channels that then connect to the spleen, to the liver. There can be involvement of the skin, other organs throughout the body, almost any place but the cornea, interestingly. Lymphoma is a complicated disease. There are, by one count, up to 106 kinds of lymphoma in the 2017 classification. Mantle cell lymphoma wasn't described until around the 80s, and it represents a special area in the lymph node, an area called the Mantle zone, which is a specific area in the lymph node, and it's a very characteristic appearance. And this really points out how, when we diagnose these diseases, how important just looking under the microscope initially is. If you go through the data that we had from the National Cancer Database, and you start out with the concept that 5% of malignancies are lymphoma, and only 4% are mantle cell lymphoma, that drives the number down. Another way to look at it is that the 1 in 200,000 patients can develop mantle cell lymphoma. Mantle cell lymphoma can be diagnosed in the peripheral blood, on a lymph node biopsy, on a bone marrow biopsy, or even extranodal tissue. It's first diagnosed by the way it looks under the microscope. Then very specific studies are performed, and they center around abnormalities in chromosome 11 and 14. This results in a dysregulation in CCND1, which then results in an overexpression of cyclin D1. And that stain on the lymph node then is diagnostic, and that's how we diagnose the disease. We then rely on some other information, and the way these can be very prognostic. The first is the appearance. If they're blastoid or very immature cells, that's an unfavorable prognostic sign. If the Ki-67 is greater than 30%, then that's an unfavorable prognostic indicator. And lastly, if there's a TP53 mutation, and that result is really important because of an observation made in 2018 by the Mantle Cell Network in Europe, where they reported on 182 patients and that underwent a transplant, and that's a standard of care. If you had a TP53 mutation, your overall response rate was in the 2.6 years versus 12 years if you didn't. And so these are the important things that we look at in diagnosing the disease and tying it into a prognostic classification. A care plan defines the direction of care that a patient will need, and mantle cell lymphoma is a complicated disease, and it can outline in a very stepwise fashion what's likely to happen, but it's important that the care plans overall were developed more for nursing care than they were for physician care. But they've become more adaptable and adapted to the broad care of patients that includes not only inpatient care, but also outpatient and long-term care, and really stresses the individualized needs of the patient, whether it be the actual treatment plan, then what the influence of other comorbid conditions are. And so what kind of other support is needed at home? What are their transportation needs? Are there needs because of wheelchair assistance and other healthcare needs like that? Care plans are really important in mantle cell lymphoma because of the natural history of the disease. 15 to 30% of patients have an indolent disease and actually can be observed. Those who are under the age of 60, who are not in that situation, or 65, the standard of care is chemotherapy and then a peripheral blood stem cell transplant. versus outpatient chemotherapy in patients over the age of 60 to 65. And so it's very critical at the outset to establish what that approach is going to be and then to incorporate the details of that kind of care plan. First-line treatments in mantle cell lymphoma are involved. First and foremost, if there's a clinical trial available, we really strongly encourage that because that's how we affect change and we make a difference. Secondly, it's age dependent. Patients over the age of 65, we use a bendamustine rituximab-based therapy, which is given every 4 weeks for 6 months, versus those patients who are under age 65, we then consider an approach, if there aren't other issues and other clinical trials, of incorporating R-CHOP with cytosine arabidoside, which is our maxi-CHOP, followed by a peripheral blood stem cell transplant, followed by rituximab. And that is the standard of care, but there are a remarkable number of clinical trials that are ongoing now internationally and nationally that are addressing how best to accomplish the initial frontline therapeutic interventions. There are a remarkable number of clinical trials that are ongoing nationally and internationally. The first trial is the Triangle trial in Europe of 861 patients, which is looking at the utilization of maintenance therapy and the question of rituximab and ibrutinib. The second trial is the SHINE trial, which randomized patients with treatment with bendamustine rituximab and ibrutinib versus bendamustine rituximab and placebo. It was just reported at ASCO. There's a significant improvement in the progression-free survival of 6.7 years versus 4.4 years, and it's likely that that will become a new standard of care. In the United States, there's trial E4151 in the Eastern Cooperative Oncology Group, which allows for patients to be treated with any regimen up front, and then there's a molecular study that's obtained. If the molecular markers are negative, then patients go on to a randomization to either rituximab as maintenance therapy or to a peripheral blood stem cell transplant. If that is still positive, then they go on to a peripheral blood stem cell transplant. And this is going to be a real important study because this could change the whole way we recommend a routine peripheral blood stem cell transplant. And this trial has been accruing very well even during the pandemic, and it's really exciting to know that this will come to fruition, and we're really looking forward to the results. ECOG 1411 trial looked at the question of lenalidomide with rituximab maintenance versus rituximab maintenance, and we're still awaiting the results of that trial. Lastly, there are different Bruton tyrosine kinase inhibitor trials that are ongoing and other clinical trials which are really going to change the landscape. And this is just an incredibly exciting time, and I think really points out how important observations in clinical trials worldwide are that change regulatory body recommendations in different countries and really change what we can do for patients and improve outcomes. In 2022, we generally consider mantle cell lymphoma as not curable. Whether or not longer-term studies with molecular markers are going to disprove that, I don't know, but I think the consensus internationally is still that. It is absolutely essential that patients be followed. So you need to be seen to have a physical examination, standard blood tests, and then intermittently bone marrow examinations, PET scans, or CT scans, and that's how we detect the disease. And in my experience, over 40 years, it can be any one of those. And you can be very asymptomatic and have significant disease. And so it's really important that you not be lost to follow-up and that you continue to be monitored.